We need to have more Indian guidelines. We need to have more Indian protocols. And I think this next decade is something where I'm really excited, and I'm hoping we will see more things where we will have our Indian kind of things going on. Okay, so without further ado, we have many things here. Okay. Okay. So this I kind of prepared more from the student's point of view. So if it's very simplistic, hopefully you can ask questions later on. So Burkitt's lymphoma was named after Dennis Burkitt. He was an Irish physician who not only gave his name to Burkitt's, but also worked on dietary fiber for the avoidance of colorectal cancer, which was a fact that I didn't know. Burkitt's lymphoma, we know it's an aggressive non-Hodgkin's lymphoma associated with Epstein-Barr virus and also HIV. We think of it as having a classic c-Myc mutation. And of course, we all know that you require intense chemotherapy. The prognosis in children is excellent, but unfortunately not so good in adults. Now, the main classification are there's the endemic type, which is more in equatorial Africa and Brazil and other countries where it's associated not only with EBV, but also holoendemic malaria, which basically means that everybody there has the malaria, has been exposed to malaria. Sporadic is what we see most of the time, and this is in children, sporadic Burkitt's makes up 20 to 30%. So anybody who's dealing with pediatric patients, you're very likely to see Burkitt's lymphoma in the adolescents and pediatric age group. In adults, it's less common, with only 1% of all lymphomas being Burkitt's. And it's more like other lymphomas, it's more common in males versus females. There is also the immunodeficiency associated, which is it's seen in organ transplant patients and HIV patients. And it's fairly common in this group of population. So it is a tumor that is derived from the germinal B cells. And as I said, we already know about the EBV and the c-Myc. There are studies in the endemic Burkitt's where it's due to the increased Plasmodium falciparum antibody titers. And in HIV, even though we say it's an immunodeficiency, it usually occurs in patients when they have a higher CD4 count. And we're not really sure about the organ transplant, what the etiology is in that. So a little bit on the EBV. So the B-cell lymphomas arise at different stages of cellular development. And the EBV antigen is very important in this, because we know that antigen presentation and T-cell recognition is how we have our immune surveillance. And what the EBNA1 protein does is that it actually, one, it confers a survival advantage, but also this expression of this may lead to immune evasion. And that is one of the reasons why Burkitt's lymphoma is actually a very interesting disease to study, because if we could understand more about immune evasion, perhaps we could think of other ways of treating lymphomas. So this immune evasion, what happens is, as you know, we have to have antigen presentation, and then you have T-cell recognition. And there are several things that happen in Burkitt's lymphoma. One, there are defects in HLA class 1 antigen processing. Then there are antigen presentation problems. And most of these arise from the EBV DNA proteins. And so with the composition of all of this, the EBNA1 proteins, they fail to inactivate CD8 positive T cells, and this is in the context of HLA class 1. And so this is one of the mechanisms that is presumed to lead to the immune evasion mechanism. MYC, we think that c-Myc is always there. Unfortunately, this is not specific for Burkitt's lymphoma, but the c-Myc, this reciprocal translocation that we see of 814 is very common, and it occurs in about 70 to 80% of Burkitt's lymphoma. And there are other MYC mutations that can be seen, and all of them lead to the cell proliferation, differentiation, and apoptosis. But as I said, MYC rearrangements are not totally specific for Burkitt's. There are many other gene overexpression that is there, but the c-MYC is really the most important, and that leads to the rapid B cell proliferation, accounting for the doubling time of 24 to 48 hours. And literally in some patients, you can see the tumor size increase over a matter of days. There are other mutations that can lead to that are also implicated, and even TP53 can be mutated and may be implicated in relapse and resistance to therapy. So some other insights in etiology, we talked about the endemic Burkitt's, and of course, EBV is very important there. The thing that is very interesting here is, even though you have, you can also have a lot of apoptosis in these genes, as well as the cell proliferation, and perhaps the Plasmodium falciparum prompts the reactivation of latent EBV. The endemic Burkitt's treatment is completely different, and these patients are actually very sensitive to therapy. The HIV patients who develop Burkitt's, they have an abnormal enzyme, cytidine deaminase, which allows the B cells to switch from IgM expression to other expression of immunoglobulin subtypes. And patients who have HIV but don't have Burkitt's, they don't express this protein. So we're not really sure how this can be used for therapy, but this is just an interesting finding. Now, as I said, Burkitt's lymphoma in adults, it's not a very common non-Hodgkin's lymphoma. Burkitt's lymphoma seems to be more common in Caucasians. We don't have that much data from Asia. So this is some Western data. And the sporadic Burkitt's that we see in children, it's about 4 per 1 million. In children less than 16, the usual age that we see in pediatrics is 3 to 12, with a peak at about 10 years. And in adults, it's much less common. So that's a little bit on the epidemiology. The histology is very classical. You can see a very high rate of both proliferation and apoptosis. And lymphoma cells are usually monomorphic population with intermediate sized mature lymphocytes. You can see the starry sky appearance, which is often due to the benign histiocytes in the background and the large vacuoles that you see. And it's a homogeneous basophilic tumor on the H&E staining. The immunohistochemistry is very classical again, where you have B cell markers that are present. You can also see the germinal center markers like CD10 and BCL6, but it's negative for BCL2, and the T cell markers and TDT are not expressed. And it's characteristically the K167 is nearly 100%. So that's a very important thing to see. And this is what the flow cytometry looks like. And the S phase fraction is very, very high. And that's why we see a lot of spontaneous TLS. The cytogenetics we already talked about, and this, if you find that in which is there in most of the Burkitt's, it's pathognomonic. It's important sometime to have a differential diagnosis, because some of the other high-grade B-cell lymphomas may cause confusion. But if you are finding a BCL2 expression, or if you're finding that the Ka67 is, less like maybe 70% or so, then you may be looking at a different thing, not Burkitt's lymphoma. So DLBCL and other and high-grade follicular lymphomas can sometimes be confused, but these are the pathognomonic things that you can differentiate it with. There is also an entity of Burkitt-like lymphoma with 11q aberration. It doesn't have MYC translocation, but the treatment and other prognosis is fairly similar. So that is just another DD that you can think about. So how do they present? So patients present with a rapidly growing mass. Often the history is weeks rather than months. they have a high LDH, high uric acid, and often they can already be in TLS by the time you see them. The primary sites are usually in the abdomen, but it can be head, neck, and other areas. In adults, often the median age is 30 years, but it can be even in elderly patients. So you need to have a high index of suspicion, and often there will be constitutional B symptoms that are there. It's rare, but can occur in even other sites like even the CNS, testes, thyroid, etc. The endemic, which we don't usually see but is classic, involves the jaw, and often these patients are malnourished at that time. Bone marrow involvement of greater than 25% would classify it as Burkitt's leukemia, though usually a pure leukemic presentation is rare. CNS involvement is usually leptomeningeal rather than parenchymal, and that can occur in all of the subtypes. So workup. It's important that you get a tissue for diagnosis. If the bone marrow is involved, the bone marrow can be done, and peripheral blood. If it's the lymph node, then you need an excisional biopsy. Sometimes pleural fluid or other fluid can be used for the diagnosis. And this is definitely an emergency. So you want to be working up these patients as soon as possible. You can suspect by microscopy flow cytometry, and the IHC can confirm. It's important to do a staging for these patients because the prognosis really depends on whether the bone marrow and CSF is involved. You can do a CT scan. You can do a PET scan, but again, time is of the essence. So it's not necessary to do a PET CT in case that's going to take time. And you need to make sure, along with your baseline labs, that you are doing the TLS markers, and you should also investigate for HIV in these patients. So staging. Now, depending on whether you have a pediatric patient or an adult patient, different stages have been used, staging protocols have been used. The St. Jude staging is routinely used for pediatric lymphomas. The Ann Arbor and the Murphy staging are commonly used in adults. The Ann Arbor system accounts more for the patient's symptoms, and the Murphy staging is good because it emphasizes the extranodal disease. And so whichever staging you use, you should be familiar with it. And I won't go into this because that's beautifully been discussed in the morning by Dr. Gaurav. Now, the prognosis is very important because these were actually the first tumors that could be cured because they are high-grade tumors. They have a lot of the cells in the S phase. You give chemotherapy, most of the tumor will be knocked out. But you do need to know the prognosis because the therapy is very aggressive. So after you've done the staging and prognosis, you should give these patients only the amount of chemo that they require. Because I still remember during my fellowship, we had a patient who had Burkitt's lymphoma and who we treated and who became aplastic after the chemotherapy. And then we had to do a bone marrow transplant for aplastic anemia because the therapy is so aggressive. So LDH is very important. Cytogenetics is important. You also need to maybe differentiate this from some of the double hit lymphomas to make sure you know what exactly you're treating. And then you can do the imaging. In patients who have bone marrow involvement, people can assess the MRD because then you can decide what to do with these patients later on. Younger patients generally have a better prognosis, with the pediatric patients having the best prognosis due to being able to tolerate the chemotherapy very well. Therapy response is important because if you're getting a poor response to especially your baseline drugs of cyclophosphamide, prednisone, VCR, then these patients are not going to do well. And if you have CNS disease, you need to make sure that you have CNS. Anyway, the therapy is CNS directed, but that worsens the prognosis. Early relapses are, again, prognostically very poor. The literature says that the developing countries' treatment is often less aggressive, and patients who have malnutrition will have more sepsis and other problems. But I think if you can take care of that, then the prognosis will be good. There is also a prognostic scoring system for adults in which age greater than 40 years, a performance status of ECOG more than 2, LDH more than 3 times, and CNS disease can stratify these patients into low risk, intermediate risk, and high risk. And accordingly, you can decide on the therapy that is to be given to these patients. So treatment planning is very important. So if you have a patient with Burkitt's lymphoma, it's just like an APML patient. This is an emergency. So you should start the treatment within 48 hours. Don't get your basic tests done, but don't kind of be very finicky that, you need this or you need that. Try and do whatever is needed to the minimum and as fast as you can. TLS, of course, we talked about. It's more likely in patients who have a higher stage disease and higher LDH, but pretty much it can happen in any Burkitt's lymphoma patient. And obviously, you all know what TLS is, so we won't go into that. The side effects of chemotherapy will be there. And most of the side effects are hematological and, of course, increased risk of infection. But good supportive care can reduce all of these things. And if you're able to give the therapy quickly and promptly, you will get a good result because, as I said, these are high-grade lymphomas and cures are possible. So what are the chemotherapy agents that we have? The earliest regimen were developed by McGrath and his colleagues at the NCI, and this was the Codox-M IVAC regimen. And Ian McGrath and his team were pediatric hematologists, so the protocols were really designed with pediatric patients. And then later on, for adult patients, this was found to be very toxic, and so other regimens like rituximab hyper-CVAD and the EPOC regimens with rituximab came in. And other protocols like CHOP and things are absolutely inadequate. So don't even think about them for the Burkitt's lymphoma. So there are many different regimens. The primary ones are these that are used for patients who are less than 60 years old. And these are the regimens used for the low-risk patients. In pediatric patients, as I said, the sporadic Burkitt's lymphoma, we stratify based on the age and the stage. If you have a pediatric patient with complete surgical resection of the disease, then just 2 cycles of chemotherapy can be given. And these patients with stage 1 and 2 disease have an excellent overall survival. If patients have residual disease after surgical resection or they have stage 3 disease, then you're going to need at least 4 cycles of the intensive regimen. And of course, all of these need to be concurrently with intrathecal prophylaxis as well. Patients who have CNS or bone marrow involvement will need further additional therapy, up to 8 cycles of dose-intensive therapy. And again, CNS-directed therapy will be required. Now, that's all very well if you have a pediatric patient, but if you have an adult patient, these are difficult because there's going to be a lot of toxicity. But again, in adults, you can use less numbers of the Codox-M if they tolerate. If with high-risk patients, you will use an additional 2 cycles more of the Codox-M IVAC. But the Ian McGrath regimen in adults was difficult because you need a lot of dose reductions, and a few patients are actually able to receive this regimen in the adult age group. So because of that, modified McGrath was developed, which had a lower dose of methotrexate and cytarabine, but it also had a slightly lower progression-free survival. And because of that, other protocols came up, including the DA-EPOC regimens with CNS disease. And this is pretty much what this is a schema of the different regimens that are available and currently used in adult patients. So rituximab is very important. When this was added to either the hyper-CVAD or the EPOC, definitely there was an improvement in the results. And now, so rituximab is pretty much standard of care in all adult patients who get on therapy for Burkitt's. The newer anti-CD20 regimens are under investigation, as are some of the newer monoclonal antibodies. So this is what we are doing right now, but in the future, future, there may be some changes. There are also some newer direct MYC inhibitors that are being looked at, as well as the anti-PD-1 agents, but those are not at the moment in common use. They're just being researched. CNS disease is very important because, one, it's a poor prognostic indicator, and there's a high chance of CNS involvement in these patients. 20% of patients will have CNS disease at presentation, and mostly it's leptomeningeal, and without prophylaxis, an additional 30 to 50% will develop CNS disease. So it's very important to incorporate CNS-directed prophylaxis, and that's important into the background. Most people use intrathecals, though the exact optimal strategy is not clear. But at the moment, most of the regimens include intrathecal chemotherapy. Now, what do you do if you have an elderly patient? This is a little bit of a gray area. This is an aggressive tumor, but obviously you need to balance the toxicity of treatment, and 13 to 17% of patients above 60 will have severe toxicity irregardless of what regimen you're choosing. So this is a little bit of a problem in our current schema. Most people are using the EPOC rituximab dose adjusted, but again, you need to evaluate your patient. So the special situations where you need to look into are relapse, because we still don't have absolute guidelines on how to manage the relapse. There are many salvage regimens that are done. You can consider autologous or allogeneic transplant, but again, this is mostly tailored to your patient. And CAR T cells, which we have a talk in the afternoon, are again something that could be explored in these relapse patients. So relapse is still an area where we don't have clear guidelines. And the HIV patients, again, you have to balance toxicity with trying to give the maximum amount of aggressive therapy. So in summary, I think it's still a very puzzling tumor. How exactly does c-MYC reduce the immunogenicity and allow this to undergo immune evasion? So I think there's a lot of interesting things there. We know that unlike most tumors, we have some paradoxical things that are going on in the immune system. We know that at the moment we need very aggressive therapy for pediatric and adult patients. The elderly and the relapse patients, we still have major advances needed. But if you have a low-risk patient and a young patient, you can effectively cure this disease. So with that, I end and open to any questions. Thank you.
Ma'am, considering this high-grade disease, generally we treat with Arcodaxim, IVAC. Even in our center, we do that. But what is your experience with RDA EPOC, and should we go for it?
So again, it really depends on your age. For the pediatric patients, we have no problem with the regimen that you're expressing. And there's not been any randomized clinical trials. So I think one of the things whenever I talk to students is you should know your protocol. A protocol that you are familiar with is always a better protocol than some protocol that your friend may be using that you are not familiar with. But as you get older patients, you are going to find that it's not going to be a regimen that's going to be tolerated. So especially if you have somebody 50, 60 years old, poor performance status, that's when you need to alter your protocol. Right.
But the response rates with DAPOC was like nearly 95%.
Yeah. So if it's tolerable and you are, you can do it, why not? Yeah.
Any more questions? Yeah, please, Faima.
So he can correct me. I saw half of the patient. One of our patients, 26-year-old, Burkitt's Luke, with multiple nodal masses as well, was treated with LMB 96 till COPAD M1. She was treated in a private sector and shifted towards in a very bad state because the funds ran out. So she was not tolerant of methotrexate in COPAD M. We were reading the data. We always go with LMB 96 or Megrath. So we went ahead with RDA EPOC. First cycle, absolutely finely she tolerated. Second cycle also she tolerated. At the end of second cycle, the LP and the IT was done. And we always do a clonality panel as well on the lumbar aspirate, which came out to be positive. So we were thinking that we'll continue with the IT-MTX since the outcome was as good as the rest of the protocol with RDA epoch. But within 2 weeks, she came to us in a state of altered sensorium. And we did a CNS imaging. She had huge deposits in the occipital and parietal lobe. So now we are in a soup. We don't know how to go ahead. What do you suggest, ma'am? She's a 26-year-old, otherwise fit patient.
Oh boy. So with the CNS disease, this is really a problem because see, again, you have to balance toxicity with results. So, if radiation is possible, that's one thing. And then she seems to have had all the other agents. It's a difficult situation. This might be an area where you want to use some of the newer B cell targeted kind of products. I think this is, she's got an early relapse on the therapy progression, right? So she never really went into remission. So I think, and looking at her toxicity, this may be an area where you want to maybe come up with something new. Unfortunately, we don't have any studies, but this is a patient where you would want to try a newer
So I
type.
think there's a compassionate access available from Roche for glofitamab.
Yeah.
So I have got, requested for one.
She came to us and we knew it was disease. Her inflammatory markers were negative. There was nothing else found. So we went ahead with hyper-CVAD B.
Okay.
And within 2 days of hyper-CVAD B, she was sitting and laughing and greeted me like, "Hi, ma'am, how are you?"
Uh-huh.
So that was a state. She's very chemosensitive.
Yeah.
So I kind of think that I undertreated with RDA epoch. Maybe there is a possibility she would have done better with McGrath or
So the R epoch dose adjuster is more for like the older patients. So I think for the younger patients, if they can tolerate, go for aggressive therapy. But like what is that cutoff? I think you have to decide depending on their disease. Yeah.
So yes,
Yeah.
I don't want to ask a question, just a comment. That this RDA epoch, once it came in Burkitt's lymphoma, the trial had most of the patients were low risk.
Yes.
So this established a role, especially low risk. If we have a young, fit patient, high risk disease, we should
That's
always
exactly
treat
what we said.
with our
That,
products
go.
are hyper.
I completely agree. I completely agree.
Take one last question.
Ma'am, you were talking about endemic Burkitt's, right? It was something very fascinating. So I thought it will be interesting too for the younger ones. I don't know, maybe I'm older. Okay, there is this polymicrobial pathogenesis. It has been well established in Burkitt's. So if you see the endemicity of endemic Burkitt, it's exactly the area where Plasmodium falciparum is also present. So you must be wondering, right? EBV is there all over the world. So why do we see endemic Burkitt only in Africa? It's the exact place where Plasmodium falciparum is also endemic too. So they say that new theories are like it's the interaction between the EBV and the Plasmodium falciparum which causes this endemic Burkitt. It's just a theory I wanted to.
Yeah, no, you're absolutely right. And they call it holoendemic. So I had to look up
So
that.
there are many such theories.
yeah.
In fact, I wrote an article on
Yeah.
COVID endemicity in where malaria is endemic, but that's too far-fetched an hypothesis. I question myself now. But yes, there's a point. Yeah,
Very
there is a point there. Yeah. So, last.
Like we can give IT-MTX along with cytarabine and hydrocortisone, like triple IT, any triple IT. Oh, okay.